All right, good morning, folks. My name is Dustin Jones. Welcome to PT on Ice daily show with the Institute of Clinical Excellence. We're coming live from Instagram. We're also coming live on Facebook. Today is Wednesday, so that means it is Jerry on Ice, where we talk all things older adults with my partner in crime, Christina Previtt. We just got back from Rapid City or Deadwood, South Dakota for the South Dakota Physical Therapy Association Spring Conference. Good morning, Robin. It was an amazing weekend. We had just under 40 very passionate clinicians in this amazing lodge in Deadwood, where we went through modern management of the older adults. That's our 2-day live course that Christine and I put on. We also have the 8-week online course called Modern Management of the Older Adult. And some common themes are starting to arise as we gather all these different clinicians in the room. I think that's one of the coolest things I didn't realize going into this, is that when you get a group of, the outpatient orthopedic therapists, you get some people from the skilled nursing facility, you get some people from home health, maybe acute care, and you put them in one room and you start to talk about how we can best serve older adults. The perspectives are amazing and the conversations are amazing. So the discussions that we have about different topics, it's so cool to get other people's perspective. And we had a good conversation on, in particular, we were talking about gait speed. So what we want to talk about today is bring up the concept and challenge our thinking of, are we teaching to the test? So let me give some background on that. So many of you all know that teachers they're in a difficult situation nowadays, to where there's so much incentive placed on how their students are performing on some of these standardized tests. I know this probably fluctuates between different states, I imagine, but there's some places where your pay may be linked to how your students perform on the standardized tests. And so with that heavy of an incentive, it influences the teachers to just teach to the test. Now that may seem, not a bad thing if the test is actually correlated to, success in the real world, for example, or success in learning. But sometimes these standardized tests may not be as great as what we think they are. And so what we're seeing is that some of these teachers are really kind of simplifying things. They may be just focusing on answering simple questions or definitions, and not really having the time or the capacity to really kind of dive into some of the nuance of critical thinking and kind of going through different cases and some of these things that we know really help with our comprehension of a topic. They may not have that luxury. So they're really trying to teach to the test to get those scores up because the incentives are so strong. Does that sound familiar, friends, to our field of physical therapy? You in the outpatient world may not be feeling this yet, but I know me in home health, my goodness, the timed up and go, gait speed, SPPB, that is something that is very valuable to my employer and very valuable to our third-party payers. There is much incentive in improving those functional outcome measures, especially in Jerry PT. And I imagine that incentive and that pressure is just going to continue to increase as we really try and demonstrate our value through these functional outcome measures. Now, I'm not saying it's a bad thing, but I'm saying we have to be aware of what that may do to our assessment process or how we're thinking. But it may end up to us teaching to the test. And this was a good conversation that we had in the course of, okay, let's say I take a gait speed. Let's say someone has a slow gait speed. They're at risk for falling. Well, do I just get them to walk faster? And the answer is kind of, sort of, yeah, but we really have to tease this out. Because with these incentives, let's say the tug, the timed up and go, the gait speed, grip strength, they have some amazing data. So I don't want to downplay that at all. The tug has some amazing data with several things, correlations with, falls risk, gait speed with risk for hospital readmission rates, grip strength with mortality. I mean, the data, you cannot ignore the data of these tests, so we need to use them. But what happens is we take these outcome measures or these proxy measurements, and we almost use them as a treatment. Your gait speed is slow, let's walk faster. That equals success. Your timed up and go is slower, let's just do a bunch of tugs and work on that time, and if your tug improves, then we're winning. Or you don't have a great grip strength, well, let's get some iron grips and just pump away, and if your grip strength gets better, then that means you've lowered your hospital readmission rates. I wish it was that simple, but sometimes it may not be that simple. We may not want to use these tests as our actual treatments. So there's a couple problems with this. We'll go through these two problems and then just end with some reflection questions I want you all to think long and hard about, especially for the outpatient folk, as you're kind of in your little silo and you may not get the big picture perspective with some of your patients. So two problems. Many of these measures, not all of them, but many of them are just proxy measurements. They're not actual assessments. They're proxy measurements, not assessments. And then two, they may not be pertinent to the person sitting in front of you. They may not be pertinent to your patient. So the first one, they're proxy measurements and not assessments. So when I say proxy, a proxy measurement is an indirect measure of the desired outcome. So let's say gait speed is an indirect measure of hospital readmission risk, for example, or gait speed may be an indirect measure of falls risk, for example. Now an assessment is when you're actually gathering the detailed information that's actually going to influence your plan of care that's going to meet that individual's needs. See the difference? So the proxy measurement, I almost view that like a screen. I'm stratifying risk for, falls risk, for example, that will then lead to a further assessment to determine, why is their gait speed slower? Why is their timed up and go slower? Why is their grip weak? Not just taking that for face value, but taking the next step and actually doing an assessment. And so what I'm observing, even in my clinical practice with the incentives that I feel and observing other clinicians, is that we'll just take that gait speed, tug, and grip strength as gait at face value and just work to improve on getting them to walk faster, but not really go a step further and ask, why is their gait slower? What actual factors are contributing to that? So what we want to do is have a good musculoskeletal exam. Obviously, that's our bread and butter. Find out, why is their gait speed slower? What is it? Are they having difficulty with single limb weight bearing, and they're having issue with that contralateral swing phase? Like, what is going on? A good musculoskeletal exam is obviously going to find give you some good details, but this is a very common theme in modern management of the older adult. We have to consider the complexity in geriatric physical therapy. Your musculoskeletal exam ain't going to cut it. You're going to get about maybe 50% of the information you need that's going to influence your plan of care. So we have to consider the whole person in front of us, consider the other systems that are involved, but we have to consider some of these other factors like medications, vision, vestibular system, sensation, the environment, social considerations. What's their nutrition like? What's their mental health? All of these things are going to influence, or are going to be factors that will influence the gait speed, the tug, their grip strength. And if you completely ignore them and focus on, their right knee pain, you're missing the boat on what you can really do to make a significant impact with these folks. So go beyond your musculoskeletal assessment. Ask some of the hard questions. Do you have interest in doing things around the house? What's your day like? Are you still, getting some social interaction with your friends and family? Let me see your medication list. Tell me what this medication is for and when do you take it? Ask some of those questions to get a better idea. They are all the gait speed, tug, grip strength. They're proxy measurements. They're not assessments. You have to go a step further if you identify someone at risk for something. We have to assess our patients. So number two. So we talked about number one. All right. So proxy measurements, not assessments. We need to assess our patients. Number two is they may not be pertinent to the person sitting in front of you. So in modern management of the older adult, we start the whole course talking about aging and how we perceive aging, but then also the concept of successful aging. And this is something that I really geek out about. Christina does as well. And there's a very particular reason we put this at the very first lecture of our course to kind of set the foundation of how we are thinking about the aging process and the people that we're serving. And I just want to share a quote from Dr. Atul Gawande. So he wrote the Checklist Manifesto. He also wrote Being Mortal, and this is from the On Being podcast that really sums up how we frame successful aging really well. So he said to Krista Tippett, my favorite interviewer, he said, the patient's goals don't line up with our goals, the provider goals. Our goal is safety, survival, and health, or an improved tug, gait speed, grip strength, while their goal, the patient's goal, may just be able to read a book in silence. And that's why you can gradually lose some functions and have some health issues along the way and yet have great satisfaction in life. They may just want to be able to read a book in silence. And I think we really need to consider this. we may want the improved timed up and go score. We may want that improved gait speed. We may want that improved grip strength, but it may not be pertinent to the person in front of you. Not to say we're going to ignore these. Yes, I'm still going to do a tug, get a gait speed. I'm going to consider those things, but they may not be the big focus of my course of care if it's not correlated to a big priority for my patient. If they just want to be able to read a book in silence, I'm going to focus there. Yes, I may, do the tug, but I'm going to formulate my plan of care around those patient-centered goals. And with older adults, we can't assume that it's, they're wanting to, return to prior level of function or, continue to improve. Some people want to stay where they are or, have a goal as simple as be able to read a book in silence, and that's perfectly fine. Let that sink into your head. That's okay. If we are serving people, that is perfectly fine, and we can do whatever we can to help make that happen. I think that's a tough lesson for a lot of us. It is for me, but it's something that I'm commonly running into in home health. I want to get people deadlifting, squatting, doing loaded carries, going up and down stairs, doing floor transfers, and sometimes they don't want to. And I can try my best to work on, the motivational interviewing and really kind of digging deep and finding out why. But sometimes, there's only so much we can do, and that's perfectly fine. But we got to try. So I'm not saying, don't do the tug, don't do the gait speed, don't do grip strength. We want to use them, obviously, but they're a great proxy measurement. They're not necessarily a great treatment. We need to assess. All right, so here's some reflection questions to think about. 1, are you teaching to the test? Are you doing some of these proxy measurements and using them as treatments and thinking that improvements in those proxy measurements equals success to your patient? Are you teaching to the test? Or are you using these tests for what they are, proxy measurements or even a screen, to indicate that you need to assess further to find out what details are actually contributing to the performance in those proxy measurements? Are you considering the other factors that are influencing those proxy measures? Are you looking at their medication list, checking their vision, vestibular system, sensation, environment, social interactions, nutrition, all these different things that can impact those proxy measurements? Are you asking those questions? I would say many likely or not. Good morning, Billy. How you doing? And so with that, we have to consider, what does success look like for our patient? It may just be being able to read a book in silence. It may not be able to deadlift, a 35-pound kettlebell like I really want them to. And we need to let that influence our course of care. All right, are you teaching to the test? Ask yourself those questions. Leave a comment in the Facebook video. I'd love to get a conversation going, especially with some of you in the outpatient ortho world, because I know this can be tough to kind of ask those questions, gather that information, especially when you only have, so much time to spend with that person. So thank you all. Big weekend next weekend. So it's April, I think 6th, 7th. We're all going to Vegas for the ice sampler. So 2 jam-packed days. They're bringing all the goods. We're each going to get, roughly, 1.5 hours to 2 hours to speak to a topic that we're very passionate about. So we're just going from 8 a.m. to 5 p.m. on Saturday and Sunday with probably a sunrise hike or 2 and a good workout afterwards. Maybe a beer. I may have a beer Saturday night. It's going to be fun. But my wife and the kid are coming. I know Jeff's family's coming, and we're going to crash a couple Airbnbs and have a good time. So we'd love for you to join. I think there's still a few seats left. So just go to ptonice.com to get that link. And otherwise, I'll talk with you all soon. See ya.